All right, everyone. Thank you for joining. Hopefully everyone can hear me okay. So a little bit of a change of pace. I actually switched this to a webinar instead of a meeting so that we could actually have folks stay anonymous if they prefer. And because we are recording this and we'll share it afterwards, I just want to make sure that everyone feels comfortable with that. And so that way we can share the content without anyone being visible. So thank you all for joining this discussion on the therapeutic application of psychedelics and the discussion around psychedelic therapy and when we will have access. So my name is Jessica Nielsen. I am an assistant professor at the University of Minnesota, and I'm also a core faculty at the Institute for Health Informatics and in the psychiatry department. And I'm also the executive director of the Psychedelic Society of Minnesota. So these are just some of my disclosures in terms of some funding that I have that supports the research that I do. I have funding from the government, from the National Institute of Mental Health. I also have funding from the University of Minnesota Foundation, which is a nonprofit organization where we've set up a fund that people can donate to and make tax-deductible donations if they actually want to help fund psychedelic research locally here in Minnesota. And I'm also a young investigator. I was granted an award from the Hefter Research Institute to do psilocybin research here at the university. I'm also, like I said, the founder and executive director of the Psychedelic Society of Minnesota. I'm the founder of Psychonauts of Minnesota, which is another organization that's not a nonprofit. And I'm also a board member for the newly formed Minnesota Temple of Plant Medicine, as well as a local organization that's also focusing on psychedelic community called Big Psych. So just a little disclaimer on some of the content that I'm going to be presenting today. So this is a talk that's designed for various people in the public sector, whether you're a patient or you're a clinician, or just somebody interested in psychedelics. Just want to make sure that this is clear. The information presented here is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment recommendations. All content, including text, graphics, images, and information that are available on this talk is for educational purposes only. If you are a patient seeking out psychedelic therapy, please contact your physician to form a plan that addresses you or your loved one's needs. And if you're interested in getting involved in clinical trials with psychedelics or any other clinical trial for that matter, you can talk to your physician or you can go to clinicaltrials.gov. And I've also created a list of some of the different clinical trials that are available right now. I'm currently updating this, but you can access that on our website. And just a little note about, clinical trials I'm hoping this talk will demystify what the process of clinical trials is if you're interested in participating as a patient. Clinical trials are not actually designed to be treatments for a specific condition. They're designed for research purposes only to determine mechanisms, safety, tolerability, and potential therapeutic efficacy for an experimental drug and whether it might be good for that condition. And so the screening and inclusion/exclusion criteria and process for enrolling people is very strict, and it can be difficult to be selected for enrollment given that, because as people that do clinical research, I'm a principal investigator myself, we have very specific criteria that we're looking for to kind of reduce variability in testing the hypothesis that we have. So it's not that this is representative of anything or trying to minimize what people are going through or the treatment that they're seeking, but because clinical trials are science experiments, we really try to minimize anything that might impact the outcome. But again, that's not designed to be treatment. And being involved in a clinical trial does not guarantee any benefit from the treatment that's being tested. And being a participant in a clinical trial can be very time intensive. And if it's a placebo-controlled trial, you could end up in the placebo group and not actually get a psychedelic. And currently the only legal psychedelic that's available in the United States is ketamine. And just another disclaimer, I'm a neuroscientist. I have a PhD in neuroscience. I study the brain. And I study the brain in the context of trauma and neuropsychiatric disorders. And I'm not a clinician or a medical doctor. Okay, so this is just a brief overview of what I'm going to talk about today. I do have a Q&A box at the bottom of your screen. You should see it on the right. There's a chat feature. You can raise your hand if you have a question, but we'll get to those at the end of the talk just so we can get through the content, but you can all put your comments or questions into those different boxes. And the Q&A kind of functions that, you know, if somebody leaves a comment and you like that comment, the more people that like it, kind of like on social media, it gets kind of upvoted so we can see kind of and prioritize which questions might be most salient. And I'll get to those first at the end of the talk. Okay. So first, I'm going to go over what is the history of psychedelics and entheogens. Next, I'm going to talk about the history of clinical research on natural and synthetic psychedelics and the war on drugs. I'll then go through the current resurgence of clinical research that's been happening recently with psychedelics. And then I'll follow and end with where the future of psychedelic-assisted therapy and research is going and what that looks like in terms of access for patients. Okay, so entheogens are, and so you might hear this term used interchangeably, psychedelics or entheogens. Entheogens is often more referred to like the natural psychedelics, ones that have been used in indigenous communities for thousands of years. So entheogens are psychoactive substances that induce alterations in perception, mood, consciousness, cognition, or behavior for the purposes of engendering spiritual development or otherwise in sacred contexts. And some of the common entheogens that we think about are psilocybin-containing mushrooms or magic mushrooms, ayahuasca, which is a tea that is native to South America. Psilocybin-containing mushrooms are native to Mexico. Ibogaine, which is a root that grows in West Africa, and mescaline-containing cacti, which are native to North America. And I do want to point out that actually psilocybin-containing mushrooms do actually grow all over the world, but they were first kind of discovered and brought into our kind of collective consciousness in the West from the supply that's grown in Mexico. So there's a long history of psychedelics and entheogens that's often minimized when talking about the modern renaissance of psychedelics, as are the harms that have been done to indigenous communities that they've been appropriated from. So entheogenic plants and fungi are central to ritualistic and traditional medical practices in indigenous cultures worldwide, and civilizations have used them for thousands of years, safely and effectively for a variety of reasons, usually as a sacred, as a sacrament to promote spiritual practice and commune with nature and with the spirit realm and ancestors. But some of the like more modern history of psychedelics, and when I mean modern, considering that these things have been around and used for thousands of years, when I say modern, 1896 may not seem very modern, but that's pretty modern in the context of thousands of years. So the earliest scientific research that we can find in that context is in 1896, mescaline was isolated from peyote by Arthur Hefter. In 1938, LSD was synthesized at the Sandoz Research Labs in Switzerland by Dr. Albert Hofmann. LSD was initially marketed as something called dilyside, and it was actually passed around quite widely to a lot of psychiatrists at the time, and it was thought that it was a way for them to kind of gain an internal experience or like a more of a subjective understanding of what was going on with some of their patients. Particularly, they thought it could help understand psychosis. And for that reason, for a long time, it was considered a psychotomimetic, which by definition is a drug that mimics psychosis. And that's kind of this terminology that's been ingrained in the minds of psychiatrists for many decades. And I'll get into why that's actually a misnomer, not true. Some of you may be aware of the kind of very controversial history of the US government, particularly the CIA, using LSD as a truth drug for interrogations, which did not go very well and was kind of dispelled with some serious harms being done in the process. And in 1959, the same person, Albert Hofmann, who synthesized LSD, was given a sample of magic mushrooms that were sent to him from Mexico, and he was able to extract and synthesize psilocybin from that. Okay, so getting back at this term psychotomimetic. So psychedelics are not psychotomimetic in kind of the way we think about them now that we know a little bit more about how they work and how they impact the brain and how people perceive information and how their brain's processing that perceptually. So I won't go into the details of this just because I'm trying to make this more digestible for a public audience. But a lot of imaging research done where basically we take pictures of the brain and try to figure out what's happening when people take psychedelics or when people are experiencing symptoms of psychosis. This paper was directly comparing brain imaging studies, MRI studies, where they looked at people on the schizophrenia spectrum and then compared that with data that was coming out from research where they were giving people various psychedelics that we would call the serotonergic or classic psychedelic. Serotonin is one of these molecules in your brain that activates a lot of things so that the brain can communicate with itself. And there were some key differences that were noted between people that are on the schizophrenia spectrum and people taking psychedelics, with the only similarity being this kind of strong existential meaning that was associated with their altered state of consciousness. So in terms of integration of entheogens into modern culture, they were popularized in the 1950s and 60s, but then became a Schedule I substance in the 1970s. And there's a lot of ideas about why they became a Schedule I substance, but it's kind of long been known that at the time that LSD and some of the other psychedelics and cannabis were being widely used in the community, it was during kind of the hippie counterculture movement, as well as the civil rights movement, where a lot of these people were exercising their First Amendment right to protest, to demand their rights, to demand not going to war, to demand to be able to, just live the way that they wanted to. And, the government at the time was realizing, well, we can't arrest people for exercising their First Amendment. So let's find out what they're doing and make that illegal, and then we can arrest them and then have an impact that way. And that's been actually admitted to by somebody in the Nixon administration. President Nixon was the president at the time that the Controlled Substances Act started in 1970. And it's just been a horrible process ever since that's just caused so much damage and harm by incarcerating people for nonviolent drug offenses. And actually, just a side note, we posted this on our social media yesterday that there was this thing going around that I think originally was in the marijuana moment, where the DEA actually has this like YouTube channel podcast where they openly admitted their long history of using drug enforcement as a tactic to oppress certain populations, particularly people of color. And so just kind of acknowledging the racist history of the Drug Enforcement Agency. So that being said, there has been a recent revival in psychedelic research. Unfortunately, in the 1970s, a lot of the research was just completely shut down. And so any progress that was being made at the time, which was quite substantial, stopped. And that was for several reasons, notwithstanding the war on drugs, but also there just wasn't enough funding at the time. There just wasn't a whole lot of people interested in keeping this moving forward other than the scientists that were doing it. So all of that collectively shut down the research. But we're actually seeing, obviously, this revival of psychedelic research, and this has been recognized by the Food and Drug Administration, which has granted breakthrough therapy designation for psilocybin for treating depression, as well as MDMA for treating PTSD. And so what that means, it doesn't mean that they're going to fast track the process of approval. So the FDA is kind of the gatekeeper for deciding what drugs can be prescribed and what has therapeutic potential or medical indications. So they just acknowledge that this is very promising, and it just kind of denotes that they're really dedicated to helping this along the process, but they're not like letting people take shortcuts or anything. So in terms of the classifications of the different psychedelics, there's quite a lot of things that we would call psychedelic. So we have the kind of classical psychedelics, and these are the ones that you think of most commonly. So there's the indolamines and the phenylalkylamines. And so these are ones that are primarily having their action in the brain by activating a very specific receptor in the brain that is kind of modulated by serotonin, which I alluded to before. This is a natural chemical in your brain that can activate different things in your brain so that your neurons can talk to each other and your brain can function normally. And so it's interesting that these substances will kind of act like that, and they kind of have this mimicry effect in your brain to something that you already have in your brain. And a lot of the research and a lot of the things that we know about serotonin was actually discovered because of the LSD research that was done in the 50s and the 60s. And I think we owe the development of SSRIs to LSD research, which isn't actually taught in medical school, which is interesting, but just kind of an interesting factoid. So some of these indolamines include things like LSD, ibogaine, and then the tryptamines. So dimethyltryptamine, which exists in so many different plants and animals, and we also have it in our own brains. 5-MeO, DMT, psilocybin. And then phenylalkylamines, these are things like mescaline and DOI. DOI is a very common research chemical that's used in animal research for studying brain changes and kind of modulating how the brain communicates with itself. It's been around for a long time, but I don't think the scientists that use it mostly in animal models are really thinking of it as a psychedelic until people started using it kind of recreationally. Then we have the entactogens. These are things like MDMA. And then you have dissociative anesthetics and other things like PCP, ketamine, and salvia. Okay. So the term psychedelic was coined in, I think, the 1950s by kind of communication between Aldous Huxley and Humphrey Osmond, where I think it's this combination of two words with these Greek origins meaning mind, or mind revealing. And so that's kind of how that term came into light, but because of everything that was going on at the time and the war on drugs, LSD really got demonized, and the term psychedelic really became this like buzzword, this demonized word that was kind of a dirty word to say. And even like talking to scientists and you say psychedelic and they kind of immediately shut down. But anyway, that's kind of the history of where that term came up. So just a little bit on the war on drugs. I won't belabor this too much. And I kind of already hinted at this, that, there was a lot of protesting that was happening at the time. And so the Controlled Substances Act was initiated to shut down protesters that were fighting the war on drugs and also fighting the civil rights movement. And, this has been wildly unsuccessful. I don't mean to satirize this, but, it's just been a kind of a ridiculous, massive failure by the government, spending billions of dollars on unnecessary resources towards incarceration for drug offenders, perpetuating significant harm to marginalized communities that are disproportionately targeted. And there's just this interesting concept that, it's the war on drugs, but it's actually more of a war of drugs, because we have all these harmful prescription drugs that are pushed on people at a very young age, giving kids Ritalin, as young as 6 years old. Whereas people can't smoke pot or do mushrooms or things like that, which seems a little bit silly, considering the safety profile of these things and what we consider to be a drug of abuse, and what's causing harm and what's addictive and things like that. So it just seems a little hypocritical. And just like I said, there's just a lot of harms. And I don't know if anyone's a DARE kid. I was a DARE kid, and I feel like that just actually made me more curious about drugs. We'll just leave it at that. In terms of like the scientific research that was happening, I did this search on PubMed. This needs to be updated, obviously. 2017 is a little old, but obviously things are probably on the same trend. But we see that there's a lot of research happening, up until the 1970, and then the Controlled Substances Act, and you see kind of this like drop in all the drug research and the publications that are happening, like the legitimate scientific research that was happening into how these things work. The exceptions to that are things like marijuana and ketamine. There's a lot of research that's been done to try to demonize marijuana, not always successfully. That I think has kept the literature kind of booming with that drug. And then obviously ketamine. It's been around for a pretty long time. It was kind of, I think, invented in the 70s as a surgical anesthetic. So there's a lot of research with it in that context. And then more recently, it's obviously been approved as a treatment and a therapy for depression. And it's just a similar trends. But if you look at, anything that's mentioning therapy, you can see that there's also kind of this increase in studies and then a drastic drop off. And then we're slowly starting to see things emerge as this research picks back up again. Okay. And this is just breaking that down by the different drugs. And, there's a lot of stuff going around around in the media about, you know, the promise of psychedelics, the fact that they're this magical cure for all your ailments, and you just need to take psychedelics and all your problems are going to go away and your mental illness is going to be cured. Most recently, or rather in 2018, How to Change Your Mind came out by Michael Pollan, which just kind of really put this into the public lexicon about like how this could potentially be something useful. And I think this really did change the game a little bit, and a lot more people started becoming interested in psychedelics. You know, and that was followed by, you know, these pharmaceutical companies popping up that are doing these large clinical trials to test whether things like psilocybin and MDMA can help treat major mental illness. And obviously the most recent thing that, if you're not aware of it, this is based on the book by Michael Pollan. I think this documentary came out this year. It's a 4-part series on Netflix that talks about LSD, psilocybin, MDMA, and peyote, and also the decriminalization movement. So there's a lot of organizations popping up that are doing research, conferences that are talking about the legitimate science, training programs, psychedelic societies, advocacy organizations trying to legalize different substances, change drug policy, promote harm reduction. So there's just a lot of information coming out and a lot of organizations to get connected with that are providing a lot of useful information and data to help support the descheduling of psychedelics and hopefully the legalization or decriminalization of them moving forward. So let's get into some of the science. I'll try to keep this fairly basic, just because, you know, a lot of this can be pretty dense, and I want this to, you know, be accessible to people that don't understand all the science. So some of the major objective effects that have been found of how psychedelics are changing our brains. There's this classic figure. I think this is actually in like the first page of Michael Pollan's book, How to Change Your Mind, where when they put people in an MRI machine, like I said, this is something that kind of takes pictures of your brain and can show activity and how the different parts of the brain are talking to each other. And so people were put in the scanner either on a placebo. Placebo means that it's kind of an inactive drug that shouldn't theoretically be doing anything. And then another group of patients that got psilocybin, and what that looks like. And you can see just kind of from this is like a machine learning representation of this complex neuroimaging data, where each of these little dots represents a network in your brain. And each of these lines that are connecting shows some what we would call functional connection, meaning that they may not be physically connected, but they sort of are active and doing something at the same time. So we would say that they're functionally connected, and there's a lot more functional connectivity when people are on psilocybin than when they're not on psilocybin. And we see interesting results where the activity within a network is decreased and the activity between networks is increased. So like parts of the brain that normally wouldn't talk to each other are now talking to each other, which is probably why you're having all of these, you know, sensory distortions, because there's just so much more activity happening and so much information flowing around your brain. And so this is just a really cool kind of trippy visualization of that data. Some more objective effects. When I say objective is like, these are things that we can measure, that we can say, you know, with a fair amount of certainty that this is happening, and we can measure it very reliably. So the brain imaging is one, and then sort of like physiological or things that are happening in the body. So very consistently, what is seen is increases in heart rate and blood pressure, as well as body temperature. But the more interesting sort of effects would be these subjective effects. So these are things that people experience, and it's more something that's like an internal experience that they have that is not quite something that we can measure definitively, but something that they can report pretty consistently as happening. And so obviously these kind of perceptual distortions are very common, where you'll see, I mean, this, I hope this GIF is coming through, where you can see this, kind of movement happening with this wolf drinking water. So a lot of people, when they close their eyes, they'll see fantastic images. Even when they have their eyes open, they might see things. Some people see, like, you know, interesting vibrations on a plant or the ocean or in the sky or clouds or something like that. And people might just have other kind of interesting subjective effects that are very common and reproducible amongst people. So one of the first kind of scientific studies that really kind of set the path in motion for a lot of the research that's happening today was a study that came out of Johns Hopkins, first published in 2006. And then a long-term follow-up was published in 2008, really trying to capture what these subjective effects are. Because a lot of times we would consider the psychedelic experience to be what we would call ineffable, where it's just not really something you can describe, but scientists and psychologists and cognitive neuroscientists try their best to come up with questions to quantify this as best they can. So there's this mystical experience questionnaire that you could administer to people, as well as other measures that can assess the intensity of meaning and meaningfulness from an experience. And so people that had never done psychedelics before, but had kind of a religious orientation or a spiritual orientation, were given psilocybin for the first time, and then asked, how meaningful was this experience compared to other things in your life, like the birth of your child or the death of a family member or getting married. And very, very robustly, most of these people claimed that it was either the top 5 or the most meaningful experience of their life. And they reported that at 2 months after the experience, and that was sustained. And they still felt that way after 14 months. So it's a pretty profound study that really kind of caught the attention of a lot of people. Like, wow, this is really interesting that this drug can produce these profound, long-lasting positive effects. So in the context of psychedelic-assisted psychotherapy, so when we're thinking about doing psychedelics and getting some benefit from them, so I think that first study, they just gave them psychedelics or psilocybin and then asked them some questions afterward. It wasn't paired with any kind of therapy. But when we're thinking about it in the context of treating mental illness and mental health disorders, it's really being designed as an adjunct to an existing evidence-based psychotherapy. So if you're already engaging with a therapist, and getting psychotherapy, taking a psychedelic sort of in between your sessions might actually help amplify the effects of that therapy and make it a little bit more effective. And you might be engaging with it a little bit better. It might have longer lasting effects. And so the idea is that our brains and our bodies really have this inner healer that psychedelics are able to awaken and unlock. So if you think about, like, if you cut yourself, and as long as you protect the wound and you get rid of all the debris and you cover it up, your body will heal. It has the machinery to heal itself. And so the same is true for what's going on inside your mind. You just need to create the right container in order for that to happen. And so, a lot of times we talk about this in the context of set and setting. And so set would be your mindset. And that extends to not only the patients, but also the therapists that are doing the therapy with the patient. And then the setting, where are you physically at and doing this therapy? So you being in a very safe place where you're not going to have interruptions or distractions, or you're not going to feel like your life is in danger, and you feel physically safe so that you can focus on what's happening in the experience and let that kind of unfold and let the inner healer take over. So like, a lot of stories you hear about bad trips, somebody went to a rock concert and there was just all this chaos happening and they had a really hard time, because that's just not the right setting if you're trying to have one of these very intense, profound mystical experiences and therapeutic experiences. So the way that it's set up is you usually have these kind of 2 therapists sitting on opposite sides of the patient, and the patient's usually laying down in a comfortable space, usually on a bed or a recliner or something like that. And the protocol is really to have the patient focus on their inward experience and try to remove distractions and just let them kind of engage with their subconscious while the drug is taking effect. And so they usually do that by putting eye shades on so they can block out any light, and then put on some sound canceling headphones, and usually listening to some instrumental music. So there's no words or anything that could be suggestive, and they can really just focus on what's coming up in their mind and in their memory. Okay. So this is a little busy. I'm not going to go into this. This is my attempt to summarize the mountain of scientific literature that's been emerging over the last couple of decades around psychedelic therapy. And so if you're curious to dig into this, if you want to nerd out on the science and the literature on this, my lab website is down here, nielsenlab.un.edu, and all the different literature that supports this is there if you want to read it. But basically, it's summarizing that all of these different drugs seem to have some sort of therapeutic indication for all these different disorders. And, a lot of these different disorders do have kind of this common core of trauma to them. And so that might be the underlying mechanism for why a lot of these things are so helpful for a broad range of mental health conditions, because it's really getting at the core of why these things have developed in people over their lifetime. But we still don't fully understand how psychedelics work in the brain. So that's kind of a speculation at this point, but it seems to track with some of the data that's coming out. So, these aren't completely innocuous substances. There are some risks and concerns to consider when taking psychedelics. So for a long time, a lot of the exclusion criteria for a lot of the clinical trials is whether people have a current diagnosis or a family history of certain major mental illnesses like schizophrenia, bipolar disorder, borderline personality disorder. This is typically because of one of the symptoms of psychosis is this altered reality monitoring, and that's heightened on psychedelics. And so if people already have a problem with that, it might amplify that. And so there's a concern of not wanting to push that too far in one direction, or there's concerns that if somebody is predisposed, where they have a primary family member, either like a parent or a sibling or a child that has one of these conditions, that especially schizophrenia and bipolar disorder, that this would push them over the edge and they would start developing symptoms. But there are studies kind of looking at whether we could potentially treat things like bipolar depression, not necessarily the mania, but maybe the depression part of bipolar disorder. And there are people with schizophrenia that claim that the psychedelics help them. So I think the field is kind of reevaluating this, but for now, across most of the studies, except those explicitly studying people with bipolar disorder, those people are typically excluded from the research. And this came out from just what was discovered in the 50s and 60s when they were trying to give psychosis patients psychedelics, and granted, probably not doing it in the right setting or with the proper psychedelic therapy training that we have now. So that caution is not unwarranted, but might be something to continually reevaluate as we learn more about how these things work. Another kind of major risk is some cardiovascular problems and pre-existing heart conditions. So like I mentioned before, some of the objective effects are these kind of increases in heart rate and blood pressure. And so if somebody already has a heart condition or uncontrolled hypertension, being on a psychedelic could potentially put them into a life-threatening state, such as a hypertensive crisis. So it's really important to make sure people are being monitored and tracked for that very carefully. And unfortunately, there have been reports of sexual assault and exploitation. This is most common in the underground, but we are getting reports of this happening in some of the clinical trials, which is unfortunate. I think one of the MAPS clinical trials in Canada, it was a dyad husband and wife couple that engaged in a sexual relationship with the participant that was getting MDMA. They were obviously fired, and a lot of retraining was done, and so that couldn't happen. But the fact that it even happened at all was a bit of a concern in terms of training and monitoring, because patients are very vulnerable when they're on these drugs. And a lot of times, if they're feeling that they're having these profound shifts and healing experiences, they might often associate that or fetishize the therapist and think that they're the ones that are helping them. And there might be this kind of transference of thinking that they're their savior. And, that might not hit the right way with a certain therapist that doesn't have that boundary in place. And so I think, some of the things they're thinking about with therapy is like making sure that the dyad isn't a married couple, that they're two people that will hold each other accountable and report each other if they do something unethical, and always making sure there's two people in the room that can monitor each other and the participant. So not going to go into the details of this. This isn't a science lecture or pharmacology lecture, but just kind of showing the different classes of the classical psychedelics I mentioned before. And just to highlight that across these three different classes of psychedelics, so we have things like the phenylalkylamines, which is like mescaline, or the tryptamines, which would be things like psilocybin or DMT and LSD. they all have this one receptor that seems to be very central to whether somebody has this psychedelic experience. Because if you actually selectively block, if you give a drug to block this receptor, you don't trip. So that's been shown in a lot of different research studies, and it's very interesting, and it seems pretty central to this. And there isn't actually any known other thing that binds to this receptor. It's pretty much just psychedelic drugs that bind to this 5-HT2A receptor, one of which, like I said, is your own naturally occurring dimethyltryptamine that exists in your brain. And we don't actually know why we have that. There's some speculations that it's a spirit molecule, that it helps your soul leave your body when you die. That's kind of hard to prove scientifically, but it is released when you die. Or if you induce cardiac arrest in rats, they produce massive amounts of DMT. So it's really interesting, but we don't really know why this molecule exists in nature. So what is the function of this receptor, given all of that? It's involved in a lot of kind of brain development and plasticity and adaptability of the brain. I won't go into the right figure, but suffice it to say that these types of receptors are very prominent in the brain when you're younger, and they degrade and reduce as you get older. And it's not just drugs, these psychedelic drugs that activate this, also extreme states of stress might activate this. And so this is something that has been common in kind of groups of like aesthetics, where it's shown on the right, where they basically will like starve themselves to induce an altered state of consciousness. So in terms of some of the like the biology of this, again, not going to go into the details, but what we're learning from animal models of psychedelics, things like LSD and DMT and DOI, is that these drugs are able to rapidly induce changes in your neurons in your brain that are responsible for making them more adaptable and malleable, so they can kind of communicate differently with each other. There's a term sometimes called neuroplasticity, but that's more of like a buzzy scientific word, but it's basically just like the brain's ability to change. And then this was replicated with psilocybin, showing a similar effect, where it actually tracked, where they showed similar increases in what these are called spines, dendritic spines, which are part of these connections that neurons make with each other, which tracked and correlated with reductions in symptoms that were associated with mental illness in humans. So these are like rat studies. And so there's this learned helplessness paradigm that is kind of this animal model of PTSD and reduction in stress-related behaviors, which suggests that it might be helping both change the brain's physical structure as well as the behavior of these animals. And I'm currently doing a cool mechanistic study that I'm not going to go into too much, but if you are interested in participating, you can check more about, you can check on that either at clinicaltrials.gov, or you can go to my lab website, and there's a link to send us some information if you want to participate and see if you're eligible. So in terms of demystifying the psychedelic trial process, so I took a screen capture of this from this website, psychedelic.support. They're a really great organization that provides a lot of education and content around psychedelics. And so in thinking about clinical trials, there's this whole process that happens in order to get the FDA to approve something. And so you have to do this in phases. And so it usually starts with some preclinical work. And so this is like stuff that's done in animals or in a petri dish, where you're trying to determine like what's actually going on with the drug, what's it binding to, how does it behave chemically, pharmacologically. And then once you've determined that, then you can go into humans. And so this is what we would call a phase 1 clinical trial. And this is typically a study that's done to assess safety and tolerability and potential like toxic levels. And this is typically done in healthy people. And so you need to do all that before you move on to a phase 2 trial. And a phase 2 trial is typically when you do like a first trial in patients, where you do a very small study in a small number of people, where you try to see if now is this treatment potentially safe in the patient population, and do we see it moving any of the, reducing any of the symptoms that you think this treatment would help. And so if that goes well, then you can scale things up and move on to a phase 3 trial. And so this is kind of the last phase before FDA will approve it. And it's usually a very large multi-center, meaning they're doing it at many different places where they all do the same protocol. They give them the same drug, so you can get enough people to say with some confidence that the drug works and it can reduce symptoms and that it's safe and that it should be approved for use in that condition. And so after that, there's what's called sometimes phase 4 trials or post-approval trials. So the drug's been approved, it's now prescribable, it's out in the market, people are using it, and they can see whether it actually holds up. And if any of the side effects become more prominent, and any of the what we call adverse events become more prominent. So sometimes you'll hear these like retractions of like, oh, this drug, it determined that this drug is like really harmful now that everyone's taking it, and then they'll pull the drug off the market. Or the data says that it's fine and it's safe and it stays in circulation for a long time. So if you're interested in joining a clinical trial, there's a website called clinicaltrials.gov where you can search all the different clinical trials. And if you're interested, usually you can contact the contact person on the website of the clinical trial. They usually list all the inclusion/exclusion criteria. So whether they're looking for a specific condition or an age range, or if they're only enrolling men or women, or if there's any specific things that would exclude you. Like a lot of times these trials require people to live fairly close to the site just because of the amount of time that you need to come in and do stuff. Or there might be some like safety concerns, like I said, if people have a history of schizophrenia, then they might be excluded. So all of that is factored in. And it's good to kind of read that when you go to the website for the clinical trial that you're interested in participating in, so that you can know whether it'll be worth your time to go through that whole process, because it can take a lot of time to get screened and evaluated, and to do all that and then be told you're not eligible can be really frustrating. So this is just a snapshot of all the clinical trials using psychedelics across the world. I think this was current as of, I don't know, 2 hours ago, and I took a screen capture of this. And just to kind of like walk you through what this looks like. So if you go to clinicaltrials.gov, I have the website right here. What you do to navigate this, to search clinical trials that are available, is first you want to type in, if you have depression or PTSD or something, you type that into the condition box, and usually as you're typing it in, it'll auto-populate depending on what they actually have a code for in the system that it can link to. And then you can, in the other terms box, they don't have like a treatment box, but this is where you would put the name of the drug that you're interested in. So in looking at psilocybin, and then you can get more specific on like, okay, is there something that's close to where I live? And so I just kind of auto-filled this just to kind of show you what that would look like if you tried to look for something in Minnesota. Is there a depression trial with psilocybin in Minnesota? The answer is no, not yet. But then it gives you these kind of other options. Well, are you just looking to be in a depression clinical trial in general in Minnesota? Or would you rather look at a psilocybin depression trial elsewhere? And there are 40 of them that exist, but they're not in Minnesota yet. So by clicking on psilocybin and depression, it'll then open up all the different studies. So there's 40 of these trials that are listed. Some of them are completed. And so these are just trials you can click on and see if there's any results posted. Some of them are in the system, but they kind of have some unknown status. Some have probably completed enrollment. So the study is considered active in the system, but they're not recruiting anymore. And then what you really want to focus on is if they're recruiting, because that means that they will have availability and they will be able to communicate with you and talk to you about whether you meet their criteria and whether you can come in and participate. So now I'm just going to give a really high-level overview of some of the clinical trials that have happened with the various entheogens over the years. And I don't want to go too much into detail because I want to leave time for questions. So I'm going to go through this kind of quickly just to do a high-level overview. Again, if you have any questions and you want to dig into any of this further during the Q&A, just put your questions in the Q&A and we can talk about it at the end. Okay. So mushrooms have been used by humans for more than 7,000 years. They were first introduced to the West by Gordon Wasson, who went down to Mexico to do a mushroom ceremony with a curandero down in Mexico named Maria Sabina. And he actually lied to her because she said, I absolutely don't want you participating in this if you're going to tell anybody about it. This is just for you. Please keep it secret. And so he said that's what he would do. And that he would keep it secret. But then as soon as he got back to the United States, he wrote an article in Life magazine and people started flooding down to Maria Sabina's town wanting to take mushrooms. And by the time she died, she was actually completely ostracized and desolate and destitute because her whole community shunned her and was very angry with her. And so it's a really sad story of how she was exploited and how that indigenous knowledge was stolen from her to kind of birth this modern renaissance in psychedelics. So I think it's important to acknowledge that history. So in terms of, like I alluded to, it activates the serotonin receptor in your brain. The experience usually lasts about 3 to 6 hours, and a moderate dose of actual like mushroom material is usually considered to be 2 to 3 grams of like dried mushroom material. Some of the therapeutic uses that are currently being investigated and have published papers on and clinical trials that have been done include addiction, depression, cluster headaches, existential anxiety, obsessive compulsive disorder, and palliative care. And so there's a lot of different clinical trials happening with psilocybin. This is just a snapshot of just the psilocybin trials in the United States. It's quite a lot. This is ours right here in Minnesota. It's the only one right now. So getting into some of the conditions, so let's kind of go through alcohol use disorder. So about 15 million people currently meet diagnosis criteria for alcohol use disorder. 28% of American adults have unhealthy alcohol use patterns, and this ends up costing our healthcare system around $250 billion related to alcohol-related health concerns. Current treatments that are available right now that are legal is like a current treatment 3-year abstinent rates. This is usually through like 12-step programs, which has a 36% success rate, which is okay, but not great. Another treatment is motivational enhancement therapy, but that has a success rate of 27%, and then other kind of cognitive behavioral coping skills at 24%. There are some pharmacological options, like I think specifically with alcohol, they give people disulfiram, which induces very intense vomiting if you drink. So it kind of tries to condition people in a negative way to not drink by making them violently ill. And those are more focused on reducing cravings or, like I said, producing unpleasant physical reactions. So getting into some of the earlier research on this, in 2015, this kind of very small, what we would call an open label study. They didn't have a placebo group. They just gave people psilocybin and monitored how they changed over time. So this was done in 10 people over 14 sessions where they were given a couple different psilocybin sessions. They paired it with motivational enhancement therapy. And so when I mean they paired it, meaning they usually get a lot of preparatory therapy. So they do this motivational enhancement therapy before the dosing session. And then the dosing session is just administered, just the drug. The therapists sit there, they don't do the psychotherapy while they're on the drug. They just let the person have their experience and hold space for them and deal with anything that comes up, but really trying to keep them focused in their experience and just kind of let them have the experience. And then the next day, and then in the weeks after, they do integrative psychotherapy, where then they try to really work on the content. Okay. And what they did was they found that a lot of the people had reductions in their drinking days, and they noticed that there was a relationship between whether people had this mystical experience, whether they found this profound meaning in the experience, and the reduction in their heavy drinking days. And more recently, this paper actually came out, I think, a couple of weeks ago. This was published in JAMA Psychiatry. This is a very prominent medical journal in the field of psychiatry. JAMA stands for the Journal of the American Medical Association. And so it's really hard to get journals published in here. They only take, really high caliber, top quality research. And so this was a randomized controlled clinical trial. So what that means is that there's 2 different groups of people that are randomized to each group. So there's like an equal chance of people being enrolled in one group or the other. And then they get either a placebo or they get the psilocybin. So that's what the RCT means. And they enrolled 93 people in this study, and they gave them either psilocybin or, this was the first study I've seen that actually the control in this study was Benadryl, basically, I guess because it induces kind of a increase in the heart rate. But it was interesting because actually the serious adverse events that were reported were only in the placebo group. So it might not be the best placebo, but anyway. So this was done at 2 different sites in the United States, in New York and New Mexico, and they basically kind of replicated what they saw before, but in a larger sample size, and confirmed by comparing it to placebo that there was significant reductions in heavy drinking days in the psilocybin group compared to their control. And this was probably a phase 2 study. Okay. So next, there's been some studies looking at psilocybin for tobacco addiction. So just a little background on tobacco addiction. Smoking-related mortalities are on the rate of about 5 million worldwide. Behavioral interventions and pharmacotherapies have not been proven to be very effective. Success rates at 6 months are less than 35%. So this study was published in 2017 by the group at Johns Hopkins. And so I think, again, this was also an open label study where there was no kind of placebo control group, and looking in a small group of 15 people, where they got 2 to 3 psilocybin sessions between a 15-week smoking cessation treatment protocol, and that was paired with cognitive behavioral therapy. And patients reported at 6 months an 80% abstinent rate, and by 12 months, 67% of the patients were still reporting that. And at 30 months, 60%. So that's a pretty good success rate, given what I just showed you, that most of those other ones were down in the 30s. And that, you know, what's that math, 12 to 30 months, you know, that's a pretty long period of time for it to only go down by 7%. So I think it's a pretty good sustainable therapeutic benefit that these people were having. Yeah, and again, this was correlated to whether they had a mid-school experience or not, and having these kind of persisting effects of positive mood and this like spiritual component. So the big one that is kind of making the headlines lately is depression, psilocybin for depression. So this is the one that I think a lot of people are throwing a lot of their eggs in the basket to get psilocybin over the finish line to get FDA approval for depression. So there's a lot of multi-site clinical trials happening for depression. Depression is one of those conditions where a lot of people will have suicidality as a symptom of depression, and suicide is a major problem. Obviously, it's the second leading cause of death among individuals 10 to 34. Depression is the leading cause of absenteeism in the workplace, and it's estimated that 300 million people suffer from depression. I think that's close to the population of the United States. And it has untold negative effects on the mind, body, and interpersonal relationships. And current pharmacological interventions are not terribly effective and don't really work for very long. So one of the first studies published on this was a small open label study from the group at Imperial College London. Robin Carhart Harris, some of you might have heard that name a lot. So he was the one running this study. And so I think they had 20 patients where they gave them psilocybin and looked at reductions in depression symptoms, and they found a significant reduction in symptoms for everyone that completed the study, and no adverse events were reported. And then recently they did another large depression clinical trial, and this was published, I think, what was this, 2021, so last year, in the New England Journal of Medicine. This is hands down the most prestigious medical journal on the planet. Getting a paper published in New England Journal of Medicine is an extremely high bar. They only take the best of the best. So the fact that this was published in that journal really speaks volumes to the legitimacy of this research and to these findings. And so this study was very interesting because as their placebo or as their control group, they basically were testing it directly against an SSRI. And it was a kind of an interesting study design because I think they had to, because obviously, you know, for a psilocybin dosing session, you just do these like full day drug dosing sessions, but SSRIs you take daily. So they had to get creative in how they actually paired these things together. So I think everyone was taking a pill daily. And so there was one group that was getting an actual SSRI, this escitalopram, taken daily. And I think the other group was taking like a placebo to the escitalopram. I think they actually got like a 1 milligram dose of psilocybin. And just to clarify, the psilocybin that's being used in these clinical trials is a synthetic form of psilocybin. So when you hear about the dose of like, oh, it's 25 milligrams or 1 milligram, 25 milligrams of synthetic pure pharmaceutical grade psilocybin is equivalent subjectively to about 3 grams of mushrooms. So they think they got like a 30 milligram dose of psilocybin for the people that got the psilocybin, but then they were taking this very, very low subperceptual dose, 1 milligram, to trick them to think maybe they were getting an SSRI, whereas the people that actually were getting SSRIs then got a placebo on the dosing days and not the psilocybin. And so on this measure, this QIDS measure that they used, which was their primary outcome in the clinical trial, when they looked at changes over time, they didn't actually see a strong significant difference between psilocybin and the escitalopram on this kind of clinical measure of depression. But what they did see was a significant difference in this measure of well-being. So even though the clinical measure wasn't suggesting that they were getting better beyond what the people in the SSRI group were, their own perception of feeling better was much higher than those that were getting the SSRI. Okay. And then this paper came out in Nature Medicine back in April. And so this is basically the same data that they reanalyzed and published in another super prestigious journal, Nature Medicine, looking at their first open label study, which actually was looking at treatment-resistant depression, which is technically looking at people that have major depressive disorder, but then they also have what we would call refractory or treatment-resistant depression, meaning that they've tried all these different therapies and nothing's worked. Compare that to the more current randomized controlled clinical trial, where they were enrolling people that just had MDD and didn't need to have treatment-resistant depression. So the depression in that group was less overall than the first open label study, but nonetheless, they were able to see significant reductions in symptoms over time. That was more significant in the psilocybin group compared to the SSRI group. Okay, so another trial that was done recently was published in JAMA Psychiatry. This is from the group at Johns Hopkins. And they did a kind of interesting design where they actually gave all the patients psilocybin, but the way that they randomized them was one group was given psilocybin therapy immediately, but then the other group was delayed so that they could kind of use the no drug and just psychotherapy as the control. And then eventually, once that was done, and they went through that course so they can compare it to the immediate group, then they gave them psilocybin. And so when you look at the reductions in depression symptoms based on who got delayed treatment or immediate treatment, those that got immediate treatment had significant reductions in their depression symptoms. But eventually when the people got psilocybin after the delayed condition, and you pull all that together, you see that everyone has these significant reductions over time. Okay. And this was a 12-month follow-up to that study where when they looked at them at 12 months, they still were showing this significant reduction in their depression symptoms, suggesting that it's a long-lasting effect from just a few treatments. So mushrooms have also been used in palliative care. And so what that means is usually palliative care is just kind of giving people additional support and health care when they have a very severe chronic illness. It doesn't necessarily mean that they're terminal or in hospice, but that they have a very severe chronic condition that's very difficult to treat. And it's really an attempt to just make them more comfortable, to improve quality of life. And there's not really any treatments for this other than I think they give people lots of opiates and things like that, which probably isn't the best to just numb people, but rather find something that can actually get them engaged and feel like they have better quality of life. And a lot of those drugs that they're giving for comfort have significant side effects, obviously. So there was a study done at NYU that was published in 2016 that gave patients that had received a life-threatening, that had a life-threatening illness. So they had, I think, a terminal cancer diagnosis. They weren't in hospice. They weren't like active. They weren't dying, but they had received a diagnosis. And some of them had actually kind of gone into remission, but the impact of having that diagnosis and having that imminent threat of death and having to evaluate that and kind of live with that reality caused them substantial anxiety and depression and existential distress. So those patients were enrolled and given psilocybin to treat that anxiety and depression associated with that kind of life-threatening condition. And they saw significant reductions in their anxiety and their depression, increased spiritual well-being and quality of life, and improved attitudes towards death, and found the experiences to be very meaningful and spiritual And importantly, in these clinical trials, there was no serious adverse events. And that's been the case for pretty much all of the clinical trials I've shown you, where a serious adverse event is something where we would say this drug is not safe, it can't be approved, the clinical trial is done. So far that hasn't happened in these trials. And what was great about this was that Johns Hopkins did a similar study. And so they both decided to publish the findings of these studies at the same time in the same issue of this journal of psychopharmacology, basically independently replicating this finding, which is a pretty big deal in science to be able to do this. And it really shows replicability and generalizability. Okay. And the study at NYU actually did a 4.5-year follow-up. So 4.5 years after they were done with their psilocybin treatment, they brought them back in and did some more assessments for, what's going on with their anxiety levels and their depression, and they still showed significant reductions in these, even, almost 5 years later from, just a handful or even, just 2 or 3 psilocybin therapy sessions, which is quite amazing that these can have such long-lasting, sustainable therapeutic effects. There's some minor evidence to suggest that mushrooms might be good for obsessive compulsive disorder. There's only really been one study to demonstrate this that was published in 2006. It was kind of more like an observational study of 9 patients that got varying doses of psilocybin that reported reductions in their OCD symptoms. But there have been a lot of case studies published in the literature about, clinicians whose OCD patients will come in and said, hey, I did magic mushrooms and I just feel so much better. And when they assess them, they're like, yeah, you seem a lot better. So while that's not like clinical evidence that would be taken seriously by the FDA as enough to like approve it as a treatment for OCD, it's interesting that this consistently pops up anecdotally from people reporting that benefit. And if anyone's kind of interested, there's this comedian, Adam Strauss, who has obsessive compulsive disorder, who actually read this paper and decided to engage on his own kind of journey of treating himself with mushrooms. And so he has this fun comedy show. I don't know if it's still in circulation, but I think it runs in San Francisco and New York, depending on where he's living at the time. And it's just a really awesome kind of first person experience of like him dealing with his OCD and how psilocybin helped him. All right, so moving on to a different substance. So there's ayahuasca. Ayahuasca is an indigenous sacrament used in the tribes of the Amazon. It's an entheogenic brew or tea that's a combination of 2 different plants, a vine that's Banisteriopsis caapi vine, which contains the monoamine oxidase inhibitor that allows the other plant that has dimethyltryptamine to be orally active. Because if you were just to like eat a plant that has DMT in it, you wouldn't feel anything because you have these enzymes in your stomach that break it down. And those enzymes are also in your brain as well, which is why even though we have DMT in our brain, we don't actually experience the effects of it. And so when you boil these 2 plants together, you get this orally active DMT that lasts for a really long time. And it's a very, very intense experience. I mean, when you think of psilocybin, that's a pretty intense experience, but this is just orders of magnitude more intense. And it usually lasts about 4 hours. And it's typically done in kind of a ceremonial context with a trained shaman that's comfortable dealing with the spirit realm that people engage with, whether people believe that exists or not. To these cultures, it's a very real thing. And these people have been trained for a very long time to navigate that spiritual world and help be a guide for people that are in this state and working with ayahuasca. So in terms of its therapeutic uses, there's been a few studies looking at addiction and depression, and then there's some sort of proposed evidence that anorexia and PTSD might be helped by ayahuasca. So this study was an observational study looking at 12 participants from the First Nations band in Canada. And it was a working with addictions and stress retreat. It was 4 days of group counseling, 2 ayahuasca ceremonies, and they were focusing on intergenerational trauma. And they did this ceremony where they stayed in their traditional communal ceremonial space and then worked with the ayahuasca in that context. And they found no adverse events, enhanced mindfulness and quality of life, and then reduction in problematic cocaine use and tobacco and alcohol use. So not everybody had the same kind of substance use, but all the people that kind of came in with some substance use disorder or problematic substance use that they wanted to treat were able to find benefit. And then another study was done in Brazil, where ayahuasca is actually legal. It's kind of like central to the culture there, and it's a religious sacrament that's used by the church down there, the Santo Daime. So they have a good supply of it to use for clinical research. And again, I just, for the sake of time, I'm going to speed up a little, but basically they were able to show significant reductions in depression symptoms compared to a placebo group when given ayahuasca. But this was people given ayahuasca in a hospital by themselves. There wasn't really a sitter. I think the patients were sitting in a room by themselves. And then there was this person sitting behind like a glass window watching them. It was kind of a weird design, but even still, they were able to have these substantial benefits from the ayahuasca. So next I'm going to move to ibogaine. So ibogaine is a plant that's native to Western Africa, used by the Bwiti religion in Gabon for healing and spiritual purposes. And it's usually used as a rite of passage for people in that community to pass into adulthood. There's been a huge demand for this, as it's been found, as it was discovered to be a very effective, what we'd call an addiction interrupter. It's not necessarily a cure for addiction, but it seems to put the brakes on people's relapse symptoms and withdrawal symptoms so that they can kick heroin more easy. There's been 75 to 100 ibogaine treatment centers established worldwide. It's become quite popular, but it is a very, very, very intense experience. So ibogaine and ayahuasca are what we would call master plants, just because of the nature of the experience and the consistent communing with spirits is very consistently reported. So with ayahuasca, people claim to see like jaguars and like this ayahuasca spirit and sometimes serpents. Whereas in ibogaine, they tend to experience and commune with their own ancestors. So it ends up being very personal. And so the first clinical research that was done with ibogaine was a little controversial. There was actually a lot of fatalities because people weren't being screened properly, especially so people coming in, and this was being done to treat like severe opioid use disorder. So people that have been addicted to heroin for very long periods of time. So their bodies weren't terribly healthy and they just couldn't tolerate this really intense treatment. So this is a 3-day trip, basically. And I don't want to go into the details of it, but it's basically this phased experience that people have that's very, very intense and not to be taken lightly, and it should be revered and respected. So there's really only been one successful clinical trial of this. So after knowing kind of this issue of like potential fatalities and serious adverse events from the previous research that was done in the 90s with this, there was a study done by Thomas Kingsley Brown, where he looked at 30 participants that had opioid use disorder. There was very careful screening and safety monitoring done, where they gave them ibogaine and saw significant reductions in their opioid withdrawal symptoms. Yeah, and I think they compared it to like treatment as usual of people doing methadone, and the treatment effects were lasted up to 12 months, which is pretty impressive. All right, and then now let's go into MDMA. So I'm not going to go into the detailed history of MDMA, but let's just say it used to be legal and it was used to treat people that had trauma back in the 70s and 80s, but then the rave culture got a hold of it and the DEA decided it needed to be a Schedule I drug and the research stopped, and that's actually when MAPS was formed, the Multidisciplinary Association for Psychedelic Studies, because Rick Doblin, who's the founder of MAPS, was actually one of these people wanting to be a therapist and was trying to go to school to be a therapist. And then all of a sudden, that became impossible. So he founded MAPS and embarked on this long journey to get MDMA approved for the thing it was being used to treat back before the DEA decided to reschedule it. So wasted billions of dollars, and how many lives could have been saved, but that's a topic for another discussion. Anyway, but hopefully it'll get approved soon. Anyway, there's been a lot of what do they call it? Fake news about MDMA that actually has put kind of a bad taste in people's mouth about whether it's really dangerous. And so some of the things that you've seen out there are actually being misreported and associated with other drugs. But then they're saying it's because of MDMA, and in fact, it's not. But people kind of remember the negative press about it rather than the corrections to that false information or misinformation. Okay. Yeah, so again, I'm going to just kind of breeze through this because I want to get to some of the access issues since we're kind of getting short on time. But MDMA seems to be really good at being able to reduce fear and anxiety and help with social interactions and helping people feel these profound states of euphoria. And sort of a lot of the work with this was done, and the synthesis of it was done by Sasha Shulgin, and a lot of the therapeutic uses of it back before it was scheduled, where it was him and his wife, Anne Shulgin. And then Annie and Michael Mithofer have been the ones really pioneering the clinical trials of MDMA for PTSD. They were the first therapy team that really kind of proposed this and doing the clinical trials in collaboration with MAPS. And again, it's this kind of two therapist protocol where, you have two therapists working with the patient that has PTSD, and you do a lot of prep sessions, and then you do the MDMA assisted session, and then you do a lot of integrative psychotherapy afterwards, similar to what's being done with the psilocybin trials. So again, like I said earlier in the talk, FDA, these studies have been granted breakthrough therapy designation by the FDA, and they're potentially on track to be approved by 2023. I'll get into a little bit more about what that means in terms of actual access. And the results from the phase 2 trials were very, very promising, and which is why they've been able to move forward with a phase 3 clinical trial. And so the results of the phase 3 clinical trial were published last year in Nature Medicine, and showed significant reductions in PTSD symptoms compared to the placebo, reductions in depression. And so that is a pretty strong finding. And so, like I said, if you remember before on sort of the trajectory of clinical trials, phase 3 is the one that is kind of the last one you need to do before the FDA will approve it. So the FDA is chewing on this data, so hopefully they will actually approve it soon. There was another small study done in 2018 looking at whether MDMA could treat social anxiety in adults with autism. So not treating autism itself, but treating the social anxiety symptom of it. And they showed, even though it was a small sample of only 12 people, they did show significant reductions in their social anxiety. And there hasn't been a whole lot of work on LSD. LSD was just so demonized because of the war on drugs and what happened in the 60s, because that was the main drug that was out in the hippie counterculture. And so there's just a lot of stigma and baggage associated with LSD. So I think a lot of people have shied away from it. And it's also a very long lasting experience. So thinking about its clinical application, that's a pretty long day for a therapist to do a 16-hour therapy session. But it's kind of got a really interesting history. It was used a lot in the 50s and 60s to treat alcohol use disorder. And it was actually kind of central to the foundation of Alcoholics Anonymous. Bill Wilson, who founded Alcoholics Anonymous, was inspired by his LSD experiences. So it's kind of interesting, although he eventually left AA because, AA is pretty much an abstinence-based organization, and they really didn't like that approach or his leanings towards that. So I think he eventually just left and stopped going to AA. But this study actually just came out last month. This is a group, I think they're in Switzerland. This guy, Matthias Liechty, he does some really cool mechanistic research with a lot of different psychedelics. If you're interested in the neuroscience of psychedelics, I encourage you to look up his research. He's kind of my idol right now in terms of looking at how psychedelics change the brain. But he actually did a randomized controlled phase 2 study with LSD to see if it helps with anxiety and life-threatening illness. So this is kind of similar to that study that was done at Hopkins and at NYU, looking at that with psilocybin. And so this is kind of another example of this, using LSD to see if that actually works. And so I won't go into the design of this, but basically people that got LSD, and they kind of randomized so that some people got LSD first and some people got placebo first, but then all people in this trial got both drugs. They just randomized which order they got. And the people that got LSD had significant reductions in both measures of anxiety, which is these top panels here, and reductions of depression, which are the bottom panels here. Okay. So ketamine is the only legal psychedelic that's available right now. It's currently FDA approved for depression. It's been around for a really long time as a surgical anesthetic, but the current FDA approved use doesn't pair it with psychotherapy. But we really think that and there's been some mechanistic research with ketamine that actually it induces these antidepressant and anti-suicidal effects through an opioid receptor. So when they block this opioid receptor, they don't see these antidepressant effects. So it just suggests that ketamine, while it might be useful for depression, it might be a little dangerous in terms of it could be habit forming and addictive. So just take that information for what it is. But there's a lot of ketamine clinics popping up that I think are being run by anesthesiologists. They're the ones that are licensed and boarded to give people ketamine. But they're not mental health professionals. And so it's not being offered in the context or paired with psychotherapy a lot of times. And so people might not be able to be getting the benefits that they otherwise could if they were to do it with psychotherapy. And you really don't want to be doing mental health therapy with somebody who isn't licensed or boarded to treat mental health disorders. So an anesthesiologist is not able to do psychotherapy. They don't have training in psychiatry. They probably did a rotation in medical school, but they really aren't licensed to do it in that context. So it's kind of borderline malpractice if there's only an anesthesiologist doing this and there's no mental health support and they're claiming that they can help your depression. So be wary when you're looking at ketamine clinics and making sure that they do have mental health staff there to support the process. And this paper was just kind of outlining the clinics that are pairing it with psychotherapy and that how well it does to reduce people's depression. So there's some training programs popping up to teach clinicians about ketamine and how to administer ketamine-assisted psychotherapy kind of within this framework of psychedelic-assisted therapy and the principles involved, given the intense altered states of consciousness that people have. And these are 2 local ketamine clinics that I would recommend, where, the staff are really great. I vouch for them. I know them. I think they're good therapists. I think they're ethical. And I think they take insurance as well. So I would encourage you to reach out to these folks if you're interested in doing ketamine therapy, which is legal at this time. And I think these clinics are setting up so that when MDMA and psilocybin become legal, they have that pipeline in place to then just add those into the clinic. So what's next? So some of you have probably been seeing these headlines going around that the Biden administration is endorsing psychedelic therapy, and really they're just recognizing that the FDA is about to approve MDMA for PTSD, and they need to set up a process for figuring out how that's going to get incorporated into insurance and what are we going to do to make sure that this is going to be something that's administered safely and according to what it was designed for through the clinical trial process and the protocols that have been developed. So I don't necessarily want to read all this, but this is taken from the psychedelic support website. And so really kind of figuring out where are we at now, because MDMA is the closest therapy that psychedelic therapy that is set to be approved. So because the phase 3 clinical trial finished in 2021, unfortunately, I think the FDA is making them do a second phase 3 clinical trial. And they're kind of making them jump through all these hoops. Okay, just do this one more thing, just do this one more thing. But they're anticipating that hopefully by late 2023, this will actually be approved by the FDA and that it could be available in medical settings as early as 2024. But I've seen this date get pushed back so many times. It was 2021, then it was 2022, now it's 2024. So hopefully it'll get approved soon and it'll actually be available in a clinic near you. But it's unclear whether insurance is going to cover this or not. But there are people kind of working with the government to figure out how to get these things incorporated into Medicare and Medicaid so it's accessible and affordable. Yeah, I think they're trying to make sure that this is going to be widely available. And I think MAPS's goal is to have 1 million patients with PTSD treated by 2031. But there's a real need to get people actually trained in this. It's not that people are just going to be prescribed MDMA and you can just take it home and do it. It's really like you go to a clinic, you have 2 trained therapists that will work with you over a period of probably at least 2 months to do your MDMA assisted psychotherapy in their clinic and not something that you do at your house. Yeah, so MAPS is recommending that therapy be required in order for patients to access MDMA. Like I said, it's not just something that you can just take home and do yourself. And so they're really trying to figure out what does that look like in terms of like implementing these training programs and making sure that it's going to actually be utilized that way. And what are the regulatory oversight and how's that actually going to be monitored and evaluated and controlled in that context. So that's MDMA. So that's obviously a lot farther along than everything else. Psilocybin is quite further from FDA approval because trials are currently in phase 2. Phase 3 studies are supposed to start within the next year. And like I said, that's the final phase needed. But there's a program in Oregon that seems to be the closest we have so far. So in 2020, Oregon actually legalized medicinal psilocybin at a statewide level. It was something they put on the ballot and the voters said, yes, we would like medical psilocybin. So if you're curious to learn more about that program, I encourage you to check out this website. You can just Google Measure 109. And then you'll kind of go to this government website. This is the Oregon State website. That kind of talks about this Oregon psilocybin services overview and kind of what that's going to look like. Yeah, so other states are also making efforts to do something similar. And there's a growing number of cities that are decriminalizing various entheogens, but decriminalization is not legalization, so they'd still technically be illegal. And cops could, decide they want to invoke county or state jurisdiction or federal jurisdiction. So I'd say tread cautiously if you're in a state that has decriminalized psychedelics. We're trying to do that here in Minnesota. But again, it's not legalization. But this program is interesting because it's not going to be something where you have to go to like a clinic to do this, I think. What is it? The psilocybin products consumed must be cultivated or produced by a licensed psilocybin manufacturer and may only be provided to a client at a licensed psilocybin service center. Yeah. Okay. So it is something where you have to kind of do it. You can't just take it home and do it yourself. I think they're only going to give it to people who are 21 and older. And there's just all kinds of speculation about how this will be implemented. If you want to go to that, if you want to look up Measure 109, they have this nice infographic PDF that you can click on. That kind of walks through what they think this process is going to look like for implementation. And then Fluence, which is one of these programs that's training therapists to be psychedelic therapists. They have this new certificate program specifically to train therapists that are licensed to practice in Oregon to be able to facilitate and be these kind of facilitators for the clients that they'll treat in Oregon only. So unfortunately, this doesn't really apply to any therapists that are not in Oregon unless you want to move there, or we can start pushing efforts to get it legalized here in Minnesota. And so getting into clinician training, there's quite a lot that's happening right now. MAPS has their own training program to train therapists to be MDMA therapy certified. So we're going to need like 30,000 therapists in order to implement this to the population. There's the program at the California Institute of Integral Studies, which actually has some modules that overlap with MAPS, so that this program is really more like theoretical, talking about the research and concepts and stuff like that, but the experiential component where a lot of people believe that if you're going to be administering psychedelic therapy, you need to have firsthand experience of what that altered state is like. So a lot of these training programs will incorporate an experiential component so that you can actually have firsthand experience with the therapy and take turns being patient and clinician. Okay. There's this online training program that, again, it's like a lot of the theory around psychedelic therapy and best practices, and then they have an optional ketamine experiential retreat to kind of give clinicians that experience. There's also a lot of just therapy and science and therapy education out there. Psychedelic Support is my favorite. They're very comprehensive. They have a lot of good stuff on their website. Some of it costs money, but they do have a lot of free content that you can take. Fluence that I just mentioned. So this is a group that I am a part of. I'm a student in their program, but they have a lot of courses that you can take. They have certificate programs for psychedelic harm reduction and integration, ketamine-assisted therapy, and then the psilocybin program in Oregon that I mentioned. So in thinking about this moving forward, it's important that we obviously train the next generation of psychedelic therapists so we have enough people to meet the demand of the patients that are going to want to use this therapy. Didn't really get into this too much, but a lot of the psychedelic research that's happening right now, if you look at the papers and the demographic characteristics of the patients, and this is true not just for psychedelics, but like pretty much all clinical research, it's predominantly, 80% white and mostly male. I'm not sure why that is. I'm kind of butting up against this myself and trying to enroll for my study, where there's just this massive interest from a certain demographic. And so I think there's really a need to get more community engaged research, especially to be able to include participants that are from more diverse populations. And a lot of that is just representation, making sure that the therapists are people that are either BIPOC or they have training on how to work with these populations and understand the unique nature of what they're coming in with and their experiences that they've had, and just making sure that that's really accounted for so that people feel safe when they're doing therapy and they feel like they're not going to have additional harms caused to them by a potentially racist therapist. I think, in that vein, focusing on more qualitative and sociological investigations might help with that. I think a lot of these very rigid, clinical, sterile environments and measures just aren't really conducive to the Indigenous uses that they, came from. And so really kind of trying to think of like, how can we incorporate more of that into how this is being implemented, not only in the clinic, but also just kind of out in the world when this gets approved in the different ways that it's going to be delivered. And then, my personal interest, I'm a neuroscientist, so really kind of pushing more towards, psychedelic neuroscience research to understand what these things are actually doing to the brain, not just therapeutically, but kind of functionally. If folks want to help support psychedelic research, there is the Psychedelic Therapy Fund at the University of Minnesota Foundation if you're interested to help. The federal government hasn't been too jazzed on funding psychedelic research. That's happening, but most of the science that you've seen was funded by private donors, lovely billionaires and other people that really want to just donate money to these research efforts. And so I just want to acknowledge a few people that have helped with some of these slides over the years. I've been giving this talk for a while. And so I'm really grateful for these folks for helping putting these slides together. So I think that was quite a long talk, but thank you all for listening, and I'll get to the Q&A. Okay. So I don't think folks can talk. So I will basically go with the ones that have been upvoted the most. So we have this first question: when it comes to set and setting, has there been much research around administration in a natural environment? That's a great question. I don't think there's been any controlled trials that have actually done this. I think that's definitely something that should be looked into. But I haven't seen that done in the clinical research setting, just because I think the argument is that it's just causing too much variability. And so it's just seen as a negative, as something that would just kind of muddy up the results. But I definitely think it should be investigated of that setting component. It's a great question. Next question, let's see. In Indigenous communities where psychedelics are a part of their culture, do you know how young of age they will give psychedelics to? Yeah, that's a good question. I don't know that I can't speak for the different Indigenous communities. I know in the Amazon and some of those communities, they do give it at a very young age. I don't know with Iboga what the rite of passage age is, whether it's teenage or not. But I do think that they do give it at a fairly young age, at least for ayahuasca. And I think, yeah, thanks, Ben Flatham, for answering that question. Okay. Next question. The world of psychedelic assisted therapy training is still very new, and it's hard to know which programs are legit, what kind of jobs will be available post-training, or whether to wait until more psychedelics are legalized. Do you have any advice for an aspiring psychedelic assisted therapist? Yeah, that's a great question. There's so many different programs popping up. The ones that I would recommend are the ones that I showed. So I think a lot of them are fairly exploitative and maybe don't have the chops or the expertise in their faculty. So, the Fluence Group, obviously MAPS is training, the California Institute of Integral Studies. Those are kind of the big ones right now that I would trust. Let's see. In terms of advice, I mean, for now, if you're trying to get involved, what a lot of therapists are doing, or they're learning how to do ketamine-assisted psychotherapy, because the same principles will apply. And so really kind of getting that training and then getting that experience working with that. And then you're kind of already working in a clinic that then has the pipeline set up to fold in MDMA and psilocybin, and then doing those additional trainings as they become available. But they are pretty expensive. Unfortunately, a lot of these training programs end up being like $10,000, which is very, very expensive. Some of them have scholarship programs, but I don't know if that helps much. So the next question, I think there is a strong pent-up demand for supervised use of psilocybin. The elephant in the room is, when can we expect treatment centers to get approved in Minnesota? Great question. Specifically for psilocybin right now, the only option is the clinical trial I'm doing, which isn't actually a treatment study. It's a mechanistic neuroscience study in healthy people. But I'm working on trying to get some treatment trials set up with some clinicians in the department and some local addiction clinics. But that's still a clinical trial. And I think engaging in clinical trials is the best option right now. But really, we kind of have to wait until these things are approved by the FDA and able to be given in a clinic. Otherwise, folks have to go in the underground, which I don't necessarily recommend. But that's kind of the option right now. Let's see, from a clinical research perspective, we will have to wait until psilocybin and ayahuasca are both FDA approved in order to study the differences in their effectiveness. So they don't need to be FDA approved to study them in research. To do a clinical trial, you just need the FDA to give you an authorization. It's basically called an investigational new drug approval, so that you can give something that's not approved yet to people in this kind of experimental context. So that kind of a study could be done theoretically. Ayahuasca, I actually was trying to do an ayahuasca clinical trial and I abandoned it because for one reason, I felt that it just wasn't ethical to study ayahuasca, just given the indigenous uses of it and the fact that there's been a lot of people that are part of the plant medicine community and shamans down there that really are asking Western researchers not to medicalize ayahuasca. And so I took heed of that and decided to focus on psilocybin. And it's also just tricky to get something like that through FDA, given the nature of its botanical like admixture of these two different plants. It's very hard to standardize within the confines and restrictions that FDA has. So it's kind of tricky. Yeah, so it's absolutely possible to do it now. It's just a logistical nightmare. Okay, so a lot of us here want to know when we can expect these substances to be available for supervised use. So like I said, yeah, once they're FDA approved, and hopefully my last slides about the timeline answered that, but it's going to be, for psilocybin, it's going to be a ways off. MDMA, probably closer to the end of 2024. Next question. I've been listening to New York Magazine podcast cover story Power Trip that has recently shaken my confidence in the MAPS trials, not just the sexual abuse with the couple in Canada, but the integrity of the research. Is this something you can speak to? Yeah, so this, I would say that is, I don't want to say it's an anomaly, but it's definitely not that prevalent. I think that was like a really bad set of therapists that did not adhere to the protocol, but also MAPS didn't do their due diligence to like actively monitor the situation. And a lot of these therapy settings, they're recording them. And so they have video that someone is supposed to be monitoring. So I think we need a lot more oversight to make sure people are doing this ethically and setting plans in place to make sure that there is more monitoring, that the dyad therapists aren't, you know, gonna like do something that they're not gonna like disclose because they have this like existing relationship. So I think making sure that husband and wife teams or people that are in a relationship aren't co-therapists is a big way to help that. And just making sure that everything is documented and people are being ethical about it. But yeah, I hear you that it kind of calls into question and makes people kind of challenge their integrity. And there's just been so many harms and abuses in clinical trials historically. You know, we do have ethics committees when it comes to clinical trials, but then what's that going to look like once this is out in the world and it's not under the purview of a you know, an ethics committee like an IRB that's used for a clinical trial. So we'll see. Where can a person receive treatment in the US? So right now, the only treatment is these ketamine clinics or getting involved in a clinical trial, but a clinical trial is an experiment and it's not a guarantee of benefit, and you could be in a placebo group. So those are kind of the options right now. And so if you're really wanting to do psychedelic assisted therapy, I would recommend looking into a ketamine clinic. All right, and then distinguishing between legalization and decriminalization. Apologies if I use that term interchangeably. So legalization means that, you know, it's considered fully legal and therefore it can be regulated and it can be marketed. And it has all these kind of restrictions on quality and things like that. Whereas decriminalization just means that it just shouldn't be on the radar of law enforcement. But then also it's not able to be commercialized potentially, because if something's decriminalized, you still can't like make money off of it. So I think with legalization, you have the opportunity for commerce. And I think we're seeing this a lot with cannabis, where it's legal and there's just kind of all these like bad actors coming onto the scene. And so I think a lot of people that are in the psychedelic community are really pushing for decriminalization rather than legalization for that reason, because it shouldn't even be a criminal issue. But it also shouldn't be something that can be exploited and mass produced by these various industries that just want to make money. Let's see, can you direct to a resource on what it would take to become a licensed psilocybin service center if it were to become legal in Minnesota? I don't really think that falls under my purview. I would recommend, if you're curious about that, to talk to a lawyer. Obviously, psilocybin would need to be FDA approved. So we would need that first. And so I would just look at seeing like, what does it take to have like a ketamine clinic or a service center, and then talk to a lawyer and see what that looks like when you're dealing with a controlled substance. All right, seems like there might be a need to have a marketing campaign with the same amount of funding like the war on drugs, but with quality, accessible information to counter some of the older negative messages about psychedelics. As these clinical trials continue and these psychedelics are approved, where do you think these messages should come from? Is this part of the distribution requirement in your grants? Information distribution, I'm assuming you mean, and not like distribution of the, dissemination requirement. Yeah, so I mean, I think just, knowledgeable people that understand the actual science, presenting it to people. I mean, I just gave a lecture to a bunch of the psychiatrists in my department, many of whom have been very skeptical of psychedelics for a very long time. And just framing it in a context of like, this is the evidence. This is what's been shown. This is what has been kind of the misinformation that was spread in the 60s. And this is what you were taught in medical school that was not correct. And here's what the reality of this is. And here's what the data says. And this is all being published in these prominent medical journals. And so I think just kind of delivering it in that context and knowing your audience can really help to change someone's mind, and sticking to the evidence and not like making assumptions or stating opinions, and just sticking to the facts and framing it to what they're interested in hearing, and making it relevant to whatever they're working on and what they're interested in. I found that to be effective. Let's see, I'm an RN working in mental health and addiction. Do you think there would be a role for nurses as well? Oh, absolutely. So a lot of these therapy training programs, they're basically looking for anyone that's a licensed clinician. So they take nurses, they take social workers, they take medical doctors that aren't necessarily psychiatrists. They'll even take like clergy, so like ordained ministers that work with people at end of life. And a lot of the people in these training programs are nurses. Absolutely. We have a nurse on our study that just helps us monitor vitals. And also, if she wanted to be involved as a sitter, we would welcome that. But yeah, there's definitely a role for nurses in this work. What about science and spirit entities? That's an interesting question. I think that would kind of fall under these like subjective effects that are kind of difficult to quantify. But if you can see a consistency, like with ayahuasca, for example, people very regularly have similar visions of these entities. And so maybe you can't prove that objectively with like imaging or things like that. But, if experientially and subjectively and qualitatively, you see these things pop up very consistently, I think there's something to argue that it's valid. But I don't know that the, hardcore scientific community would ever take it seriously, unfortunately, given that's it's not an objective measure. Is there any training for prescribers who can prescribe psychedelics? So I think that would fall under the same purview of going through the psychedelic assisted therapy program. And so prescribers, you can prescribe ketamine. Right now, you can't prescribe a Schedule I drug, which is what LSD and MDMA and psilocybin are. You'd have to have a Schedule I license, but that's not for prescribing. That's pretty much only for research purposes. So they have to be rescheduled before they can be prescribed. And I just think the same process will happen in terms of like these therapy programs that are able to administer psychedelics once they get their certification. And then you'll be able to prescribe within the context of a psychedelic assisted therapy modality that's approved by whatever agency is going to decide which training program is legit, and whether it gets incorporated into like the APA or the AMA has yet to be worked out. Okay. Will big pharma corrupt psilocybin? Potentially. I think there's a lot of controversy right now around Compass Pathways, which is one of the other pharmaceutical companies producing psilocybin, because they've been trying to patent a lot of stuff. And but USANA also has, this is the other pharmaceutical company producing psilocybin. They have their own issues as well. You know, it's tricky because they all have this profit motive. And so I think that's an argument, like there is this medical model that's passing through, but I also want to push for like the decrim model and just, you know, making these things accessible outside of the context of therapy. And then, you know, like for mushrooms, for example, like it's kind of ridiculous that we're going through this whole pipeline to make synthetic psilocybin when you can just grow mushrooms and no one really can have a monopoly on that. So decriminalization would really help give people their own agency to grow their own medicine, which I hope will happen and be part of this kind of process. All right, and final question, can any medical provider prescribe ketamine in Minnesota or only anesthesiologists? So I'm not a prescriber, so I think as long as you have, if you are a prescriber and you're able to do that, because I know like nurse practitioners can prescribe, medical doctors can prescribe. I don't think you need to only be an anesthesiologist. Any medical doctor has, you know, a Schedule 2, 3, 4. They have like at least a Schedule 2 license from the DEA, meaning anything that's a Schedule 2 or lower that they can prescribe as a medical doctor or a prescriber. So I think that should work. But again, I'm not a prescriber myself, so I don't know that I can answer that fairly confidently. Okay, so I apologize for going 11 minutes over. Thank you so much for all your wonderful questions and engagement. I really appreciate your attention.